Hi everyone, my name is Karan Raman and I am a medical student at the University of British Columbia. In this video, we will speak about determining the extent of burn injury. The learning objectives for this video include discussing the importance of an accurate assessment of burn extent and burn depth, differences in adults and children regarding burn extent calculation, methods to calculate burn extent, and lastly, referral criteria to escalate care to a dedicated burn center. An accurate assessment of the total body surface area burned is vital in the management of our patients. For instance, TBSA is required to determine whether or not fluid resuscitation should be initiated. In burns larger than 20% of total body surface area, these will often require fluid support. For the initial rate of resuscitation, the Parkline formula uses TBSA as a key variable. As such, an accurate assessment of TBSA is crucial in both indicating a fluid need and subsequently preventing over and under resuscitation. Likewise, it's generally accepted that burns larger than 30 to 40% of TBSA will require ICU support and intubation. For additional care, the American Burn Association has produced guidelines for transfer decisions to a dedicated burn center. These guidelines often gauge burn severity based on TBSA. Referral criteria will be discussed towards the end of this presentation. Lastly, TBSA has historically served as a prognostic factor, both in mortality and morbidity. The standardized variable allows patients to be stratified accurately for research and novel advances. Prior to accurately assessing TBSA burn, an understanding of burn depth is required. The most popular methods for estimating TBSA only include burns that are second degree or worse, also known as partial and full thickness burns. The reason being, with superficial first degree burns, the function of the skin remains largely intact. They require minimal to no treatment and will heal with no scarring. An incorporation of first degree burns would overestimate fluid resuscitation requirements. Depth can be broadly separated into three categories. First degree burns are superficial burns affecting only the epidermis. Second degree burns, also termed partial thickness burns, are further classified as superficial, intermediate, and deep relative to depth of dermis penetration. Third degree burns, also known as full thickness burns, encompass the entirety of the epidermis, dermis, and often extending into the subcutaneous tissues. Please keep in mind burn wound conversion. This is when a burn progresses from superficial partial thickness to deep partial thickness or full thickness. This progression often occurs over the initial 48 to 72 hours following injury. As such, final TBSA calculations can be more accurately assessed at 48 to 72 hours after injury, as there is no longer any additional progression in the depth of the injury. When calculating the percent of TBSA burned, there are three widely accepted methods to do so. The rule of nines is a quick rule of thumb which works by dividing the body into segments representing 9% TBSA or a multiple thereof. The palmar method, in which an individual's palm size, including the closed fingers, represents approximately 1% of TBSA. The palmar method is excellent for irregularly shaped and patterned burns. The most accurate and gold standard for assessing TBSA is the Lund and browder chart. Each of the three methods have their own inherent strengths and benefits and will be discussed later in this presentation. For children, to evaluate TBSA burned, we utilize either the Palmer method or the Lund and browder chart. The rule of nines does not apply to children 14 years of age or younger. This is due to children having a greater proportion of their TBSA allocated to their heads relative to the rest of their bodies. The conventional rule of nines would lead to a poor assessment of TBSA injured. The rule of nines assigns percentages of skin surface to different body areas in multiples of 9 as described in the diagram on screen. It is a quick tool to assess TBSA affected and guide subsequent treatment decisions. Ideally, the rule of nines should be used in patients over the age of 14, weighing between 10 and 80 kilograms and with a non-obese BMI. If only a portion of a segment is burned, TBSA can be calculated based on the percentage of that site burned, not the whole value. For instance, if half of the anterior abdomen were burned, that would represent a 9% TBSA burn. The limitations to the rule of nines primarily concerns obese and, as previously mentioned, pediatric patients. With obese patients, the rule of nines underestimates the TBSA attributed to their larger trunk size while simultaneously overestimating the proportion attributable to the lower limbs. The Palmer method assumes that the palmar surface of the hand including the closed fingers, represents approximately 1% of an individual's TBSA. The simple method is quick to use in both adults and children. It is particularly useful in scattered burns, burns that are irregularly shaped and distributed on a patient's body. Conversely, the palmar method can be used to estimate the area not burned in injuries encompassing a very large TBSA, as this is a quicker exercise than direct estimation of TBSA burn. However, just like the rule of nines, we are only provided with an estimate of burn extent. The method is largely amenable to both user and patient variability and estimation errors. Not to mention, it is quite inconvenient to utilize in larger burns. The gold standard for accurate TBSA burn assessment in all age groups is the Lund browder chart. To utilize the chart, the medical professional would draw an outline of the burn on both the anterior and posterior body diagrams. The chart subdivides body areas into segments, and it assigns a proportionate percentage of body surface to each segment based on the patient's age. In particular, as the patient ages, the surface area allocated to the head decreases, whereas the lower limb allocation increases. This is keeping in line with physiologic changes. Additionally, the chart is standardized to increase inter-user reliability and can relay information regarding burn depth. However, no tool is without its shortfalls. The Lund browder chart, while conveying additional granularity, is also tougher to use, requires the chart to be physically available for documentation, and requires estimations introducing user variability. Official examples of the interactive Lund browder charts used at our local hospitals may be found towards the end of our presentation. In this example, a 21-year-old presents to the emergency room with a painful, red, blistering, moist, and blanching burn covering the entire anterior abdomen and 2/3 of the anterior left arm, extending from their fingertips to the anterior cubital fossa. They also have a painful, warm, red, dry, and blanching, patchy burn on their back as shown in the slide. A part of your secondary survey, you determine the burns on the anterior abdomen and left arm are second degree in depth, whereas the patchy injury on the back is a superficial first degree burn. You then proceed to calculate the TBSA injured. With our 21-year-old patient, we can use either the rule of nines for a quick estimation of TBSA injured or the more accurate Lund browder chart. Remember, we only account for burns that are second degree or worse. As such, the patchy burn to the back, which is first degree, will not be included in our estimation. With the rule of nines, we would estimate their TBSA burn as follows: 18% for the entire anterior abdomen, and approximately 2/3 of the volar left forearm represents 3% for a total TBSA burn of 21%. Whereas with the Lund browder chart, the entire anterior abdomen represents 13%, the volar hand is 1.5%, and the volar forearm represents another 1.5%. This gives us a total TBSA burn of 16%. For interest, we have included the American Burn Association referral criteria for escalating the care of an acute burn patient to a major burn center. The multidisciplinary burn team will possess the specialized expertise for both acute care and ongoing rehabilitation. Of note, a thorough history and physical examination assessing both burn severity in extent and depth is vital to making the appropriate referral. In this video, we reviewed the following learning objectives. Thank you for listening, and we hope that you found the video educational. If you are interested, additional readings and examples may be found in our reference slides.